got other comments and things, welcome to share. Please do. I think in the past 5 years, the precipitous for this talk really comes from the fact that I think we're inheriting patients who are on high or moderate to high doses of opioids and a lot of times for pain or for a medical thing. And the patients don't think that they've got a substance use disorder, and they may not even meet the criteria for the DSM-5. But from a safety standpoint, we may want to, for a variety of reasons, we may want to consider tapering opioids. And so we're going to cover some reasons why we might want to taper those. I think a real big key to this whole talk is how we communicate with our patients and how we verbalize and we engage in our patients to hit goals, and then go over some basic steps in transitioning or people off of or decreasing doses of opioids. Part of this was taken, I'm sorry, this is 2016 CDC guidelines. This has subsequently been revised in 2022. As I verbally stay here, I think I might have the wrong slide deck that doesn't have the 2022 guidelines updated, but with this slide, as I'm skimming through it, I don't think the 2022 really saw a significant change here. The CDC guidelines recognize that people over 50 morphine milligram equivalent is felt to have an increased risk of overdose death, and that number, as the MMEs go up, increases, as you guys know, with 90 and 100 being other cutoffs that are commonly used. So I'm just beginning with one of our cases, because I think with using the echo model, being able to use cases to teach, I think is really helpful with. So Mr. T is a 54-year-old patient with chronic low back pain who's new to our practice. He's on oxycodone, acetaminophen daily, and takes morphine sustained release daily, and for a total of 150 morphine milligram equivalents. He reports significant constipation. He's got a history of obstructive sleep apnea. He uses CPAP, but infrequently. And he's not any adjunct treatments at this time. A PDMP is pulled, or a PMP report is pulled, and it's appropriate. His urine drug screen is positive for oxycodone and opioids only, is negative for 6-methylacetylmorphine and fentanyl, and he reports no other substance abuse. So as you kind of thinking through this in your minds, and I'm going to try to watch the chat as well as present at the same time, when should we consider tapering an opioid, and how might we communicate that with our patient? And I think it becomes much more complicated when he's new to our practice, and we don't have that trust, that physician-patient trust or relationship. We haven't been able to establish that yet. So as far as things to consider when discontinuing or taper is, if the patient requests a reduction, I think we want to be able to be there and support the patient as we start doing this. A lot of, just as kind of the disclosure, the ER doc in me thinks in terms of acute management, but most of this talk is really concentrated on people who are chronically on the medication. If they exhibit signs of substance use disorder, I think aberrant behavior, diversion, refusing monitoring, I think that's a time where we may not necessarily want to stop the drug abruptly. And I would suggest that if we stop it abruptly, that's likely going to result in harm to the patient. But that's a really important time to screen a patient for a substance use disorder, because if we can intervene with their substance use disorder now before they turn to their whoever's dispensing the drugs on the street, that's a whole nother level that we start looking at. If there's some immediate harms or risks to themselves or to others, they've had an overdose from their opioid, they're presenting to the clinic, intoxicated or under the influence, those would be other times where, hey, we probably need to push this a little bit quicker. When we, if another point that the CDC guideline brings up is if after a time of meaningful improvement, we're not seeing an improvement in clinical function, it would be start to look down or to titrate down. You'll also appreciate here that the CDC, if you trained in my generation of physicians on the 0 to 10 pain score, we're trying to get patients down, but really orientating our pain goal to having the patient's pain under control from a function standpoint and trying to achieve their pain function goals. So instead of, my goal is to get you to be pain-free, what are your goals? What do you want to achieve from a pain? Most of my patients they want to be grandma and grandpa when the grandkids come over. And so we'll work to be able to do that. Also asking what their goals are oftentimes sets us up to in what direction do we need to go for consultation or bring other people within medicine into help. If they're using a benzo as well, we'll talk more about this, but I think it can be really difficult to get people off of benzodiazepines, probably harder in general. Everybody's different, but in general, it can be harder than opioids. So that's something that maybe is a little bit slower. I tend to go with one drug at a time. I think, this slide is from Snehal, and I always appreciate him and his work. But this is when he internally has kind of a checkpoint in his system and asking a question, why is he thinking that we should come off? Because a lot of times our biases come into play here. And so if we're thinking a patient is a good patient, they're a bad patient, the patient deserves pain medicine, that I should trust a patient, that a patient should be rewarded or punished, and how they go. Those are all things that are probably not the appropriate way that we should be making a decision, or should be a minimum drawing attention to some internal biases that we may have regarding that patient. And a more objective and a better approach is weighing, with it as we would with any other condition. Does the benefit of what I'm proposed of the treatment plan outweigh the potential risks of doing that? And with that, tapering opioids isn't risk-free either, and it potentially is or has been demonstrated in a variety of studies to actually be potentially harmful. This is one that I like from JAMA, and what we're seeing is more of these very, very large studies done looking at insurance data in the US. And here they're looking at 10 years worth of data, and they're looking at people who were prescribed a stable long-term opioid prescription therapy, and then they were tapered off of it. And what was statistically significant, there was an increased risk of overdose, and there was an increased risk of mental health crisis. Mental health crisis is, again, coming from insurance papers, generally means an admission to a psychiatric hospital for that level of crisis. So again, not benign. While not in the slides that I have here, there have been attacks against healthcare providers from patients desperate or completely frustrated, including one murder. Two, and so us as healthcare people, it potentially creates some risk here. So, and I tell those stories because I think it leads well into this next one, is some of the goals of tapering our medication. So if you take nothing home from this echo, outside of this one point, I'm going to be happy, is we need to get the patient on board. We need to have them believing or trusting in this process. And there's a variety, and a lot of the things that we're going to talk about next is how to kind of get the patient on board. So one of the things also is, I think, asking the underlying question, why is this patient on opioids in the first place? And do they have co-occurring conditions that are going to make it harder to get off? If I had such debilitating back pain that I was unable to go to work and my joys of day was binge watching Netflix all day. I mean, that just sounds depressing just thinking about it. Um, and and so a lot of times with this patient population, there are high rates of depression that are ongoing because they've had to give up activities, things that they've enjoyed doing. Additionally, there's oftentimes some generalized anxiety, just the thought of having to get up out of bed to go to the bathroom and how bad the back pain is going to be is just anxiety provoking a patient. And so screening them and getting some of their depression under control, at the same time, the SNRIs have been shown to be pretty effective as well as the TCAs in helping to control chronic pain as well. And again, that chronic pain just takes a toll on our mental health. If we do taper slowly. Um, Again, as if we taper rapidly, we're going to get the hyperalgesia that we would with withdrawing that opioid. There, and we know that we may have some withdrawal symptoms. And I think it to help get the patient on board, educate the patient, take a moment to say, hey, if you're feeling miserable when you're going down, it might not be the thing to do, or we might need, let me know. You're going to have, or you're going to have a couple of days of where you're just going to feel a little bit worse pain, and that's the neuroreceptors hitting your receptors. So let's prophylactically start by taking some acetaminophen or ibuprofen to kind of counteract some of that. Um, Having the nurse or ourselves check in with the patient as we're coming down, I think, really demonstrates I mean, patients love it when the doctor or the nurse's office calls them. It's like a highlight of their day just to see how they were doing. But it just means that we're kind of going a little bit above and beyond, and we're invested in them personally. I think, if the preventing of overdose is cautioning and tell patients, hey, as you're coming down, we know that there's an increased risk of overdose. And if your pain's not controlled or this isn't working for you, as your healthcare provider, I want to be involved. I want to be the first one to know. And if the taper's not working for you, we can slow it. We've got options, and we can do things with that. And this is a me thing, but I like to give my patients some control over the taper. So usually we're looking um, at decreasing about 10% over the course of a month. And to me, and some of this is if they're on, is sometimes they don't like, if they're on 10 milligram doses of oxycodone, they don't make a 9 milligram tablet, right? So what I like to tell my patients, and what seems to resonate with them, is like, look, we have our good pain days and we have our bad pain days. And on your bad pain days, take the normal dosing, take what you usually do. But on a good pain day, skip a dose. And over the course of the next month before we see each other, um, and they're on, say, 120 tablets over the course of a month, can you skip um, a, a dose or two every week? And you choose it when you're feeling better. And again, that the patient generally they have some control in that, and it's easier to write the scripts. And then when they come back and say, hey, we did really well. I know you didn't think you could do it, but I'm really glad that you did. And let's try it next month. Seems to help. Again, reinforcing patient communication, involve them with that shared decision making. Going back to our original case with Mr. T, is I'm probably wouldn't taper the dose on his first visit because he's been stable at that. But I'd have the talk that, hey, what are your pain goals? Where do you want to be? How do I help you achieve those pain goals? Um, Asking him those type of questions, and say, so your objectives are, let's get an evaluation um, from an orthopedic doctor about or a spine surgeon about your back. Let's come up with some other things that we could potentially be doing. Maybe a physical therapist, with it being back pain. I know insurance oftentimes doesn't cover it, but there's a really incredible amount of very, very effective literature demonstrated in many studies with um, acupuncture. Maybe their insurance will cover a visit to a chiropractor. Have they tried that for doing it? or kind of some of those approaches. And then over the next month, let's come back and let's see how that goes. Because again, if if their acupuncture if they're able to get in and that is helping with their pain, they're not going to be taking as much opioid, and it's going to make the taper much easier. Always a question that people ask is what to taper first. And this I go back to, first line on this slide is shared patient decision making. What does the patient, what are they wanting to come off of first? I think in the 2020s here in New Mexico, I just see so few prescriptions of crisaprotol or Soma. Thank you for not prescribing that drug. It's a drug that I wish would be just taken off the market because I don't think there's much medicinal value in. But that's one that, again, I think we could just take off of. Converting people from a long-acting opioid to a short-acting opioid, I think is another positive movement. Allow patients to take the opioid as they need it for pain, not as we want to basally cover them. As I alluded to, benzos can be tricky to get people off. Certainly, after they've been on benzos for 3 months or more, there's no studies that demonstrate any effectiveness. I say 3 months, but really even a month, we start questioning the effectiveness on benzos. And then the last is just the short-acting opioids, because again, the people are trying to cope with their pain or their back pain, and they just had a bad pain day, and they just need something to provide them relief so they can sleep or function the next day. These are Alford kind of had developed some different boxes on different reasons we might want to taper. And I think, again, key things. My second thing, if you could take home anything, is if they have a substance use disorder, just begin engaging them into treatment. If you need, give me a call here at the Poison Center, and I will walk you through this if you're uncomfortable with the transition to it. And if you have it's been quite a while since I've transitioned somebody from oxycodone, and I miss those good old days of oxycodone or heroin, transitioning them to care, but we can do it. If they're diverting, I think this needs some more questions. Obviously, we can't there's legalities on keeping them on it for a long period of time. This is one place where I think urine drug testing is helpful. And are they even taking it? There is a street value in buprenorphine or Suboxone on the street, and if they're completely selling all of it, that somebody, and there's none in their system, that's to me somebody that should be able to taper off really quickly. If the patient's worried about withdrawal phenomenon, this is somebody that I would at least send to here in Albuquerque, the CARE campus, but it's just kind of an observed facility where if somebody's going through fluoride withdrawal, that we could stop and step in to intervene. But again, if they're truly diverting all of it, which is actually the unusual case, they're usually getting through some, but not all of it. If you
messed me up.
If they're diverting buprenorphine, again, we have the injectables, and both manufacturers of the injectables tell me that insurance prior authorizations aren't needed like they used to be. If there's an immediate risk to harm or themselves, those are probably over weeks or months to come down. If they're a therapeutic failure of opioids, let's come down months. And if there's, and again, not rushing any of this. So let's see. Just check and see how I'm doing on time. So our case continues with Mr. T. He expressed his concern over his medications, and in my experience, this is pretty typical for our patients, that they wish there was a way that they could cut down, and that we've talked about this higher risk, and we also talk about his risk for nighttime hypoxia with his obstructive sleep apnea, and so we get some of his treatment goals, and that he continues to want. That he doesn't feel that he's meeting his functional goals. And we discussed some evidence-based approaches that we have not been tried in doing that. So it's some things to kind of consider as we go through these next couple of slides, which is kind of going to be a bit of a review, is how might we taper some of the analgesics with Mr. T, and what adjuncts might be helpful for him. And so again, kind of some of the principles on how to taper, and just as another slide with some more visuals to really try to reinforce this. Go slow, and like I said, about a 10% over a week or a month, I think is a good starting point for this. Consider giving the patient some ability or some say in when that reduction is going to occur. If we need to consult or bring some specialists in, like by all means, let's do that. But, and I think knowing what their functional goal is will be much better. Provide some support to the patients as they go through this. Like I said, just a quick phone call to check up on them. How's their mental health doing through this? And knowing that those lines of communication are open, and if they're struggling, they'll be okay. And then continue encouraging patients, and that, let them know that you're going to be with them. And if this doesn't go well or this goes bad, that we're not going to give up on the patient, that they're not failing. We need to readjust the treatment plan and really focus on the treatment plan. We need to make changes so that the patient doesn't feel like they failed you, or their family, or that you failed them. But we need to make changes to the treatment plan. If as we do the taper and we adjust, kind of the goal here is we want to keep going down. If a patient hits kind of a plateau, is like, okay, you've been doing pretty good, let's give this one more month to try. Because generally, I don't know, in our lives, of the ups and the downs of life, you know we have some successes, and we do well, but then we have some setbacks. And if they're just having a bad month, or they've re-exacerbated their back pain, that's not a time to be decreasing. But when they're having some good times, it builds that encouragement, that confidence that they can do it. So as the way this case concludes, um, is the buying in is a very gradual pain taper with his medications, and Mr. T, given his chronic back pain, actually did very well with the TENS unit, just getting those muscles to fatigue and breaking that reflex arc of those back spasms, and it was engaging with physical therapy to a good response. Also started him on duloxetine and titrated him up to 60 milligrams a day, and then our plan was to follow him up in 2 weeks. Um, I've got one more slide, and I wish Donna was on, because I think Donna always speaks well to this. I think, that moment when we drive home from work, or take a moment to kind of self-care, because I think, especially 10, 15 years ago, when we were trying to abruptly take these patients off, and the patients were miserable, and you got the feeling that I was doing my patient a disservice too, is that we're reflecting on our self-care, and why we went into medicine, and how we're helping our patients. I think, we've all had our days where we're off too, and I think our patients can tell, they can appreciate it. People like Evelyn are much more attuned to this than I am, when people are off. Um, and our therapists, we will function, and we will do that. But if there's something that we didn't do as well, I think it also builds a lot of trust to check in with the patient and just say, hey, I've been worried about you. I worried about you last night when I went home. You doing okay? And the patient says, no, I wasn't doing good, and goes, well, all right. Well, I'm glad I gave you a call. Here, could we make this adjustment, or could we make that adjustment? Those are the things that go so far with our patients. And usually those are just a quick 5-minute phone call. Um, and if the patient fails this, are the alternatives are that they can always find this stuff on the street, and we'll always want to stop that from happening, because once they start getting stuff and find out how cheap and easy it is from the street, usually the trust is broken in the healthcare system. The substance use disorder sets in really quick, and getting them back into treatment is just so much harder when they've lost the trust in us. Also, feel free to run these cases by a colleague. I think, I think that the Echoes too would invite you to share your stories with us. And also with our stories, feel free to share your success stories with us too. Because I think it is, I think sometimes the Echoes, when we're asking clarifying questions, you didn't ask this, you didn't ask that. It's like, man, I'm looking silly in front of my colleagues, but it's okay to say we didn't ask or we don't know. We're trying to help you through this, and then being able to say I didn't ask those questions, but I still had a good ending is always a good way to end the hour. And so with that, let me call that with the slides. Again, I want to open this up to questions, and feedback and comments.